Ladies and gentlemen, thank you for standing by. Welcome to the ASTHO and NACCHO Understanding the CMS Proposed Rule on Emergency Preparedness webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you would like to use, you can also use the chat feature located on the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Monday, March 10, 2014. I would now like to turn the conference over to Laura Bisadecki, Director of Strategic Partnerships, Outreach, and Education at NACCHO. Please go ahead.
Well, thank you very much. On behalf of NACCHO, I'd like to welcome you to this webinar. We appreciate the fact that as many of our members are participating on this call as there are, and that for those of you who have submitted comments on the proposed rule. And we will be submitting these comments to the Federal Register by March 31st and have summarized them into 4 major themes, which are monitoring authority, staffing, coordination and tracking of the different plans, and unfunded training and testing. We look forward to hearing from the participants in this webinar, and as always, if our members have any questions, please don't hesitate to contact us separately. Thank you.
Hello, everyone. My name is Garrett Bacher. I'm the Senior Director for Public Health Preparedness and Security at ASTHO. We're very excited about the large turnout of this session. On behalf of ASTHO and our Executive Director, Dr. Paul Jarris, I want to also welcome you and thank you for joining us for this very important discussion. Working together with our friends at NACCHO, we're pleased to offer this session to help you better understand how these requirements will affect state and local health preparedness programs. These rules were proposed last December, and the public comment period has now been extended until late March. So we hope that following today's presentation, if you haven't already, that you'll take the time to thoroughly review these rules and submit your comments to help craft the final product. And now to introduce our speaker today is Greg Margolis, the Director of the Division of Health Systems and Health Policy at ASPR. Greg?
Well, thank you, Garrett, and it's a pleasure to be with all of you today. I'm also excited about the large turnout and glad that everybody was able to join us. I will introduce our colleague from CMS in just a moment, but I do want to make a couple of opening remarks and put a little bit of context into our presentation today, but I'll do my very best to keep it short. As Garrett mentioned, I work for the Assistant Secretary for Preparedness and Response, and we have been working closely with our CMS colleagues in the development of the proposed rule for emergency preparedness over the last number of years. But I do want to emphasize that this really is CMS's rule. And while we are essentially the internal subject matter experts on preparedness at HHS, clearly the Center for Medicare and Medicaid Services are the experts in conditions of participation and what the Medicare and Medicaid programs are expecting of facilities in order to participate in those 2 programs. ASPR is very much in support of the proposed rule, and we believe that this rule is going to help better serve the healthcare needs of all Americans during disasters. This is really a big step forward for improving our nation's health security, and in particular, it really asks healthcare providers and suppliers to take reasonable precautions and reasonable steps in order to assure that their patients' health and safety are reasonably assured during disasters and public health emergencies. So we're really pleased to have been able to work with CMS on this, and it is a pleasure to have a chance to introduce Lisa Parker, who has been a stalwart partner through a number of years in the development of these proposals. She is the Director of Divisional Institutional Quality Standards in the Center for Medicare and Medicaid Center for Clinical Standards and Quality, often abbreviated CCSQ. I want to just make a couple of quick comments before I turn it over to Ms. Parker. One is that CMS generally does not do these sorts of webinars or outreach engagements with individual stakeholders in the rulemaking process. They do a number of open doors and broad webinars about these sorts of things, but we're very appreciative of the fact that they were willing to meet with ASTHO and NACCHO and our state and local health department colleagues, as we know that you are a particularly important stakeholder in this rule. But generally, they do engagements about the rules in a much more open door way, if you will. Part of the reason for that, and I'll just mention that there are very, very strict rules about how the rulemaking process has to go. The types of things that Ms. Parker is going to be able to comment on are very much dependent on the fact that we are still in the data gathering and feedback gathering phase of the proposed rule. So I know she'll explain about what the path is forward, but I hope you'll also understand that there are a lot of rules regarding what kinds of things she can say and what kinds of things she can't. But I also know that you'll find her presentation to be particularly insightful. So with that, I'll turn things over to Ms. Parker, and thank you for your participation.
Okay. Hello, everyone. Thank you for having me. I'm going to talk about the Emergency Preparedness Rule that we proposed a couple months ago. But before I get started, I think I'll just give you a bit of background on where I work and what we do. So I work in the Clinical Standards Group in CMS, which is a relatively small group comprised of clinicians and attorneys and folks with reg writing experience. And what our function is within the agency is to establish and maintain the Medicare conditions of participation. And what the conditions, or COPS as they're sometimes referred to, is a set of regulations that apply to all providers that participate in the Medicare program that establish minimum health and safety standards that these providers must comply with in order to participate in Medicare and receive Medicare payments. The regulations apply to all patients served by a facility, not only Medicare recipients, and the requirements vary depending on the type of provider, but there are some common threads. Generally, most providers have requirements regarding governance or administration, for example, medical records, quality assessment. Some of them have requirements regarding care planning. Compliance with these requirements is generally determined through survey processes conducted either by state survey agencies or by accrediting organizations such as the Joint Commission. In promulgating regulations for providers and conditions of participation, one of the challenges that we face is that we're tasked with developing requirements that can apply to all providers. So requirements that would, for example, apply to a multi-hospital system, or just a sole proprietary long-term care facility or a small rural hospital. Our regulations have to apply to all types of unique providers. So one challenge is setting requirements that are feasible for implementation for everyone. And in doing that, we strive to strike a balance between the important need to maintain patient safety and a certain level of quality, and also the burden that our requirements can sometimes pose on providers. So, next slide, please. So for this particular regulation, it's been a long time in the making. We've been working on it, starting with the wake of Katrina, where some systematic gaps were identified. And there was certainly a clear need and, in fact, a demand for this type of regulation, evidenced by numerous GAO and OIG reports on the state of preparedness of the nation and of the nation's healthcare providers. In addition, as we continue to work on the regulation over the years, when another disaster would occur, we would receive numerous inquiries about, when is the reg coming? What are you guys doing? We need help. We need guidance. So we've been working on it for a long time. And just to give you a bit of information about our process, in developing this regulation, we looked at all of the conditions of participation that we have for Medicare providers, and we found that the existing requirements are inconsistent at best. We didn't feel like our regs were sufficient to address the need for communication and coordination, contingency planning, and also training. So one of the goals in this regulation is to provide a regulatory framework to ensure a coordinated emergency preparedness process. We began to look at existing standards to determine best practices, and we also work very closely with ASPR to develop standards that we believe meet our goals and core elements that we think can be implemented across provider types, but that are flexible enough to allow providers to implement the requirements in a way that best suits their needs. Next slide, please. Okay, so right now where we are in the rulemaking process is we've published a proposed rule. The comment period closes on March 31st, and the rule will not become effective until we issue a final regulation. By statute, we have 3 years after the publication of the proposed rule to publish a final rule. So we will publish a final rule no later than December 27, 2016. We did extend the comment period because of the scope and complexity of the regulation, and we received a couple requests from stakeholders asking for more time to review it. It is a quite lengthy document. I'll just talk to you a little bit about how it's set up. It's basically a preamble, which is the narrative part of the regulation in the beginning that talks about our intentions, gives examples, and then the regulations text in the back, which is the actual requirements that the facilities will have to follow. So the preamble talks extensively about the current state of emergency preparedness and cites many resources throughout. Presidential directives, work done by ASPR and the CDC, and also at some point gives a brief analysis of the state and local preparedness activities. The preamble is divided up so that the requirements are discussed by provider type, and this rule applies to 17 Medicare and Medicaid providers and suppliers. So just to name a few: hospitals, of course, long-term care facilities, ambulatory surgical centers, ESRD facilities, a variety of clinics. The rule also has at the back an appendix of resources that we cite in the preamble, as well as additional resources that providers can use to help them implement their emergency preparedness plans. Next, please. So in our research and consultation, we identified 4 elements that we believe are essential to an effective emergency preparedness framework. And those elements are risk assessment and planning, policies and procedures, communication plans, and training and testing programs. The hospital conditions of participation are the most comprehensive. They have the most requirements. And this is the case because we believe that hospitals are likely to be the focal point during a disaster, and therefore in a better position to coordinate with other providers as well as state and local officials, and to some extent serve as an example of preparedness within the healthcare community. So the hospital regs are the template that we use to then develop regulations for the other 16 providers. And what I'm going to go through next is I'm going to speak about each one of the elements, and what I'm actually doing is giving you an overview of the requirements for hospitals, and I'll talk a little bit later about how those requirements differ for other types of providers. But when we talk about hospitals, we're seeing all of the possible requirements that any provider could possibly have. Next, please. Okay. So the first element is risk assessment and planning. And this element requires a hospital to develop an emergency plan based on a risk assessment. The preamble has, again, an extensive discussion of resources that are available for emergency planning from HHS agencies such as HRSA and ASPR, and also other resources available through the Joint Commission and the National Fire Protection Association, for example. So the emergency plan must be based on a documented risk assessment using an all-hazards approach. And in the preamble, we talk about an all-hazards approach being an integrated approach that doesn't specifically address every possible threat, but ensures that providers have capacity to address a broad range of related emergencies. We would expect hospitals in doing their risk assessment to, for example, identify business functions that should continue, identify risks that hospitals are likely to confront, identify contingencies, consider the location of the hospital, and determine whether arrangements with other hospitals or other providers in the community is necessary to ensure that needed health services are provided during an emergency. The emergency plan must also include strategies to address events identified in the risk assessment. So the plan should consider plans for evacuating or sheltering in place or working with other providers in the area, and should specify the strategies of how those things will take place. The plan needs to address patient population, continuity of operations, succession planning. So, for example, for operations, the emergency plan and the hospital would want to consider the number of beds, whether or not the hospital has an ED or a trauma center, the availability of staff and supplies, and we want succession planning also accounted for in the plan so that the lines of authority are clear and the emergency plan can be implemented efficiently and promptly. And then finally, with regard to the emergency plan, it needs to ensure that there's a process for cooperation and collaboration with local, tribal, regional, state, or federal emergency preparedness officials to ensure an integrated response. And these efforts at collaboration must be documented by the hospital. In addition, we also encourage very strongly in the preamble of the rule the use of healthcare coalitions. We believe that a successful response requires collaboration with critical partners, including emergency management officials, public health officials, mental and behavioral health providers, as well as faith-based or community-based partners. And so we see some of the benefits of participation in healthcare coalitions as mutual risk assessments, developing standardized tools and plans and processes, joint training exercises, and of course resource management during an emergency. And the emergency plan and basically all of the elements require annual updates, but we have solicited comment on the usefulness and feasibility of updating these elements annually. Next, please. Okay. So the hospital is required to develop and implement policies and procedures based on the emergency plan and the risk assessment. So I'll talk a bit about the elements that need to be included in the policies and procedures. At a minimum, policies must address the provision of subsistence needs, whether the hospital makes a decision to evacuate or to shelter in place. And one of the reasons we have solicited comments on this requirement, in fact, we talked in the preamble about the fact that we made it such that they had to provide subsistence whether they evacuate or stay in place, because a hospital, as the focal point during certain types of disasters, will not only have to care for its patients, but may have to provide subsistence needs for volunteers, individuals in the community who are coming to the hospital to seek shelter. And in addition, to the extent that a hospital has to relocate, it needs to plan for providing subsistence needs for its patients and staff once those folks are relocated to an alternate location. The policies and procedures need to include a system to track location of staff and patients. And in the preamble, we talk about some tools that are available for that. But the point of it is to make sure that there's accurate and readily available information about the location of patients available. There must be policies and procedures for safe evacuation. So the hospital needs to consider care and treatment needs, transportation, and of course identify alternative locations or evacuation locations. A means to shelter in place. So the hospital should consider the ability of their building to survive a disaster and any proactive steps that can be taken prior to an emergency in terms of a means to shelter in place. There also needs to be policies for a system to preserve medical documentation. And that system would need to ensure confidentiality in compliance with HIPAA requirements. The preamble does include a link to a document that HIPAA prepared regarding medical records, the use and retention of medical records during an emergency. They need to have policies regarding the use of volunteers and the role of state and federal health officials. And the preamble does suggest some sources of volunteers, such as the Medical Reserve Corps, where members are screened and trained before participating in emergency activity. The policies should also address arrangements with other hospitals to receive patients in the event of limitation or cessation of operations. And then the policies should also talk about the hospital's role under an 1135 waiver, which is a section of the statute that allows the secretary to waive certain requirements during an emergency, such as EMTALA or such as the conditions of participation, to ensure the availability of health services. Next, please. Okay. The other element, I think this is the third element of the Emergency Preparedness Program, would be the communication plan. So the communication plan must include the names and contact info for physicians, other hospitals, volunteers, as well as state and local officials. And we require this so that hospitals will be able to quickly make the appropriate contacts to begin to initiate the emergency plan. They also have to have procedures for primary and alternate means of communicating with hospital staff and emergency preparedness officials, as well as emergency management agencies. So the preamble talks about alternate means such as cell phones, satellite systems, and we also solicit comments on difficulties that providers in certain areas, such as rural providers, might have with their current communication systems, and looking for things that they can do to improve their communication in an emergency. So the communication plan must also allow for a method to share patient information and medical records, including the general location and condition of the patients, and then a method to share information regarding occupancy needs and the hospital's ability to provide assistance. Next, please. Okay, the fourth element of the Emergency Preparedness Program would be the training and testing program. And this element requires that the facility develop and maintain training and testing programs including initial training and policies and procedures. And this training should be provided for all staff, including volunteers as well as contractors and others who provide services under arrangement at the hospital. The hospital would be required to also maintain documentation of this training and would be required to demonstrate that staff has knowledge of the procedures, the emergency preparedness procedures. In addition to training, we would require testing of the emergency preparedness plan through annual participation in community mock disaster drills or facility drills if community drills are not available. And we do have a provision stating that if an actual emergency that requires activation of the emergency plan occurs, that the hospital is exempt from the mock disaster drills from 1 year from the inception of the disaster, the actual disaster. In addition, we have a requirement that the hospital should participate in a tabletop drill, which is basically a facilitated discussion of a narrated emergency situation using clinically relevant emergency scenarios where questions are asked and situations are raised to test the emergency plan. And then finally, the hospital should analyze its responses to the various drills and maintain documentation of those drills. Okay, and the last element, which just applies to some inpatient facilities, is emergency and standby power systems. So this requirement applies to hospitals, critical access hospitals, and long-term care facilities. And what we require here is that the generators must be located in accordance with NFPA requirements, and in addition to that, that they be tested every 12 months for a minimum of 4 consecutive hours at 100% load, and that the hospital maintain documentation of this testing. In addition, we require that the hospital must maintain sufficient fuel to maintain power for the duration of the emergency or until a resupply is likely to occur. I will note on the generator requirements that in terms of the comments that we've received so far, this one is drawing the most interest, and we've basically heard from folks that they believe it's pretty burdensome and wonder if the burden is worth the benefit. In addition, people have expressed some environmental concerns that may be associated with this additional running of generators. So we're definitely looking into these issues and look forward to hearing from you and other commenters on that. Next, please. Oh, I'm sorry, I think I forgot to say next. So that's the slide for emergency and standby power systems. And if you could give me the next one. Thank you. So the regulation, because it applies to 17 providers, is definitely not a one-size-fits-all approach. We have tried to vary the requirements so that they meet the unique needs of the individual provider types, but also that they are flexible enough so that each provider will be able to implement them in the way that they best see fit. So, for example, some requirements may be best met for facilities that are in systems. Some requirements may be best met at the system level, while other requirements may be met at the facility level. So for training, for example, or developing consistent practices, that may be something that happens at the system level, but other parts of the emergency preparedness plan, such as subsistence needs, for example, would need to be examined on a facility basis. So just to give you a few examples, outpatient providers generally are not required to meet the provisions regarding subsistence needs. Home health agencies and hospices would be required to inform authorities of patients who may be in need of assistance or evacuation. And then long-term care facilities psychiatric residential treatment facilities must share information from the emergency plan with residents of the facility as well as their family members or representatives. And then there aren't any tracking requirements for outpatient providers, as we believe that these providers are likely to close during an emergency or to cancel appointments. Next, please. So as I've mentioned, the proposed rule does point to numerous resources and sites. In addition to that, CMS has for several years issued a recommended tool for effective healthcare facility planning, and it's an emergency preparedness checklist that really tracks very closely to the requirements of the regulation and is an option for providers to use in developing emergency preparedness plans. And then once the proposed rule becomes final, CMS will issue what we call interpretive guidelines, which are the detailed guidelines that surveyors use in determining compliance and that facilities will also use to see how day-to-day we mean for our regulations to be implemented. Next, please. Okay, so just to give you a little bit of information about moving forward, the public comment period does close on March the 31st, and we would love to hear from you. We encourage comments on all of the issues set forth in the regulation. In a couple places, we ask specific questions that we would like to have answers to. What is most helpful to us in terms of comments are comments that have evidence, anecdotal evidence, data that supports or refutes any of the positions that we've taken, but comments that not only state an opinion but have something with it to back it up we find extremely helpful. And just about the process moving forward, after the close of the comment period, we'll begin drafting the final rule, which I said would need to be issued no later than 3 years after the publication of the proposed rule. And once that final rule is published, it will become effective and facilities will actually have to comply with it sometime after publication. We have solicited comments on a feasible effective date. So whether some of the requirements should be staggered, whether because it's been so long, we should make it effective as soon as possible. So we look forward to comments on that. And just in terms of the comments, we've received a little bit over 100 comments so far. Last time I checked last week, we hadn't received any of the national organizations yet. They usually don't come in until the end. Generators is one of the big issues, apparently, and other commenters are talking about the burden for small facilities. Some commenters feel the requirements are excessive, and then other commenters feel that we need to provide more specificity. We have received some supportive comments stating that the rule is much needed and long overdue. So that ends the formal part of my presentation. I thank you very much for having me, and we're available for questions.
Thank you. And ladies and gentlemen, if you'd like to register for a question, please press the 1 followed by the 4 on your telephone. You'll hear a 3-tone prompt to acknowledge your request. If your question has been answered and you would like to withdraw your registration, please press the 1 followed by the 3. You may also submit chat questions by using our chat feature located in the lower left corner of your screen. One moment, please, for the first question. And as a reminder, ladies and gentlemen, to register for a question, please press 1-4. This is the operator. We have a question from the line of Joe Claiborne. Please proceed. Ms. Claiborne, your line is live.
Yes, I'd like clarification on the part that says clinics, rehab agencies, and public health agencies as providers of outpatient physical therapy and speech-language pathology. Does that apply to all clinics or just those that provide rehab and speech pathology?
Right. It would apply to clinics that offer the services for which we have Medicare conditions of participation. So it would be the speech language pathology, the rehab, and then we also have conditions of participation for federally qualified health care centers and also rural health clinics. So it would apply to those providers.
And our next question comes from the line of Tim D'Elia. Please proceed.
Yes, I wanted to clarify on the generator. You're requiring that under the new rule that we would run at least once a year under full load?
Yes, sir, for 4 hours, 4
Okay.
continuous hours.
Yes, ma'am. And that's annually, right? Once a year?
The regulations say at least once every 12 months.
Yes, ma'am. Thank you.
Mm-hmm.
And our next question comes from the line of Linda Scott. Please proceed.
Yeah, hi. Thank you for a great presentation. You have a room full of individuals here that work at state public health, and we've been working really hard with some of our partners on emergency preparedness. And we're very supportive of the proposed regulation, but my question gets to training of state-level survey teams, and how will that be implemented for this particular, if it's passed?
Mm-hmm. Well, similar to when we make any other type of major changes to the conditions of participation, state surveyors will be trained on these requirements by CMS. We offer annual surveyor training for hospitals and for long-term care facilities, so they will be trained as part of our normal training of state surveyors.
And this may be premature, but do you know yet, will this be a similar potential harm type of citation if they don't meet the regulations? Or you're not really haven't gone there yet?
And I'm not the survey and certification expert. We have another group in CMS that does that, but once the regs are finalized, they'll issue the interpretive guidelines about how all of these requirements should actually be cited on a survey.
Perfect. Thank you.
And ladies and gentlemen, to register for a question, press 1-4. And we do have a question from the line of Debbie Peck. Please proceed.
Hi, I'm from Emergency Management in the state of Florida, and I'm wondering, since we already review a lot of disaster plans for the facilities, will this cause an additional burden for those types of facilities that we do not review?
Well, in the rule, we have a write-up on the burden that we anticipate will be imposed by the regulation. So for hospitals, we talk about the fact that the Joint Commission requirements are similar to what we have. So while 80%, just about 80% of hospitals are accredited by the Joint Commission, we don't anticipate that there will be a significant additional burden on a substantial number of hospitals. But we are soliciting comments on the cost and on the burden and on our estimates of that burden. So for other facilities, because as I stated in the beginning, some facilities had no requirements with regard to emergency preparedness. To the extent that they aren't doing anything now, yes, there will be some burden associated with the implementation of these requirements.
Okay, thank you.
And our next question comes from the line of Johnny Lopez. Please proceed.
Yes, hi. You were mentioning going back to the emergency standby generators, that the requirement's going to be a 100% load of the nameplate of the generator, or is it the load of the building? Two different things. 100% of the nameplate of the generator or the load of the building. What is the interpretation?
We do not get that specific in the regulation. I would ask if that's a distinction you feel we need to make, that you definitely submit a comment. But I can tell you what the regulation says is that the emergency generator test load must be 100% of the load the hospital anticipates it will require during an emergency.
Okay, so that right there, it says that is the load of the building that is providing the emergency power to. Okay, thank you very much.
Our next question comes from the line of Joe Craig. Please proceed.
Yeah, this is Jim Craig in Mississippi. Great presentation, and thank you for taking time to share it with us today. Just one little quick note, the checklist that you provided in your slides, I was trying to go ahead and get a copy of it, and it comes back with a page not found. So if we could check on that link.
Okay, well what I can do is I'll do that, and I'll actually provide the document itself to your organization.
That'd be great. Thank you very much. And of course, in Mississippi, after Katrina, we've by regulation required emergency plans at all of our facilities for a few years now, and we look to try to be in sync as we have these new regulations come out with our state planning requirements as well. On the note of the generators, I think we've learned in a number of responses here in Mississippi that just having emergency circuits that don't include laundry and other facilities for extended power outages are not a good thing, and I believe we all support these regulations to be in place is a good thing for health care. But I had two real questions. The home health agency and hospice patient information piece, is that something that would be a requirement and accessible during times of emergency, or is that some way a system that local authorities would have information for where those needs would be?
Right. We would expect, and like I said in the beginning, we try not to get too prescriptive on how facilities should actually implement these requirements to allow a certain modicum of flexibility. But we would expect that these agencies, home health and hospice, will be able to inform officials of patients in need of evacuation. And but they would not need to provide occupancy information. I'm not sure if that answers your question.
Well, I just, again, from years of responding in Mississippi, for the advance notice events like a hurricane, you have a little bit of time to contact the home health agencies and find out what the needs are, versus a no-notice event such as a tornado or earthquake, where you don't have that advance notice, and it's kind of good if there's a system in place for them to go ahead and be able to access what those needs are, instead of trying to make contact with people that need to be evacuated now on an immediate or more acute nature.
Mm-hmm. We don't require a system, but to the extent one is available in your state, it certainly sounds like a feasible approach to meet the requirement.
Okay. And the second was on exercises. Can you elaborate a little bit about what you think the understanding of exercise requirements will be for, let's say, just hospitals?
Okay, you mean like the tabletop exercises, or it would be a community mock drill, or a facility drill, or it could be a tabletop exercise, which could consist of a seminar, a workshop, some type of group discussion where the emergency plan is tested. It could be games, for example, a simulation of operations during an emergency.
And do you know if you would anticipate any paperwork or documentation for the survey team to be able to review to ensure that exercise was conducted any special way?
Well, not any particular way, but there should be documentation of the exercises, and there should be also documentation of any drills to present to the surveyors.
Great. Well, thank you again for a great presentation.
But the regs don't require a specific type of exercise to be conducted, is what I was trying to tell you.
I understand. Thank you very much for the presentation and for your time.
Thank you.
And as a final reminder, to register for a question, please press 1-4.
Hi, this is Laura Bajsadecki at NACCHO, and we had a question.
Okay.
The rule does not clearly state who will be enforcing or monitoring compliance by the medical facilities and providers. Local health departments believe that the authority to monitor and track Medicare and Medicaid participating providers and suppliers lies at the local level. Can you please clarify?
Well, the Medicare conditions of participation, compliance with the Medicare conditions of participation is determined through the survey process. So, for example, for nursing homes, they're surveyed by the state survey agency on an annual basis, where surveyors come out, they're trained on the conditions, and they look at, whether or not they're in compliance. They give them citations, and then they have the opportunity for a corrective action plan. Our responsibility to do that, however, doesn't negate any state licensing or state regulations that would also need to be enforced. So it's not mutually exclusive. Was there a second part to your question?
Well, I think there is the training and technical assistance piece to it that the requirements that are still unclear in terms of who would be conducting that.
Okay, so the facilities will be responsible for conducting their own training and testing, of course, using whatever state or federal resources are available for those activities. And then again, the CMS survey agencies or the accrediting organizations that have authority through CMS to survey facilities will be ensuring compliance.
Okay. Thank you. That's very helpful. We appreciate the comments.
Mm-hmm.
And our next question comes from the line of Kelly Carr. Please proceed.
Good afternoon. The question I had pertains to hospitals and other congregate care facilities under their policies and procedures where they're required to provide for the subsistence needs of their evacuees, patients, and staff. Is the intent in the proposed rule that the sending facility would be responsible for food and water for the evacuated patient and staff even upon arrival at a receiving facility? And is that true even where the receiving facility is not under the control of the sending facility?
Yes, it is our intention that the sending facility provide for the subsistence needs of the evacuees. And in the preamble, we discussed that they could, for example, arrange to have some supplies off-site at a storage facility, or have contracts with suppliers for the acquisition of supplies during an emergency. But it is it's not our intention that the receiving facility all of a sudden be able to provide subsistence needs for these individuals, but that the facility, in developing its emergency plan, think about how it would provide for folks that it has to send elsewhere. But conversely, I think the point is that we're encouraging providers to think outside the walls of their facility. So to think about the fact that they may need to send patients and employees to another location, but also that they may need to receive people if another hospital goes down. So to think about it on both ends and to provide subsistence needs, to consider how to do that in either circumstance. And we did include a specific solicitation of comments on that issue.
And our next question comes from the line of Gary Harris. Please proceed.
Yes, I was just wondering, the Quality and Risk Director here at my hospital at JFK in Indio, California, we're wanting to know if this is going to be, did you record this webinar and we'll be able to access it again later so I can go over it with her too?
I don't know if the organizers have an answer to that one.
Yes, the webinar is being recorded.
Okay,
and it should be archived.
Oh, sorry.
Go ahead.
Will you be sending out the link for us to be able to go back and review it again, or?
Yeah, for those that have registered, we'll be able to do that.
Okay, that's all I wanted to know. Thank you very much.
Sure, no problem.
Our next question comes from the line of Mike Jones. Please proceed.
Yes, I'm looking at the home health versus the hospital, and you've asterisked the home health and the hospice, that their requirements will be the same as the hospital for the emergency plan and the training and testing. Is there a minimum on the home health as far as who the home health serves? Because some of these folks down here in Texas are mom and pop organizations. They might only serve 3, maybe 2 people in the area. So are they going to be held to the standards of a risk assessment for all hazards?
If they participate in the Medicare program and receive payment from Medicare, then they would need to meet these requirements.
Okay. All right. All right, thanks.
Mm-hmm. But in terms of the risk assessment, one of the things that we do talk about in the preamble is leveraging healthcare coalitions and using the coalitions to do community-wide assessments, and thereby and leveraging the expertise that may exist in coalitions, and with the hopes of reducing burden on some of the smaller providers.
We may only have time for one more question.
Our next question is from the line of Lee Bedridge. Please proceed.
Hi, I was just wondering if there are any plans to expand this to EMS, ambulance service providers, as Medicare Medicaid components. There would be certainly a lot of this is applicable to them as far as planning and training and exercising. So I was wondering any comments you had about that.
Right. We don't include them right now because we don't have conditions of participation for those providers, so there's really not a framework within this context to add emergency preparedness requirements. However, we'd love to hear that in comments and would definitely take it under advisement.
Okay. Thank you.
Ms. Parker, I'll turn the call back to you.
Okay.
This is Greg Margolis from ASPR, and I'd like to take an opportunity to once again thank Ms. Parker, our colleague from CMS, for taking time to participate in this webinar. Again, CMS recognizes the important partnership with state and local health departments, and we're really pleased that they were willing to do this webinar for our ASTHO and NACCHO colleagues. And with that, I'd like to again thank all of you for participating. It's really exciting to see so many people on this call, and I will turn things back over to ASTHO and NACCHO.
Nothing to add, Greg, but thank you to all of the participants.
On behalf of NACCHO,
With that,
thank you all very much.
I guess we're done. Thank you all very much. You can disconnect now.
And ladies and gentlemen, that does conclude the webinar for today. We thank you for your participation and ask that you please disconnect your lines.